Thank you, Mark. Good morning, everyone. So, as we stressed by Mark, there's been a lot of hope regarding triple therapy 2 years ago when it was arrived on the market. But the paradox is that the patients that most needed treatment, that are patients with cirrhosis and treatment-experienced patients, the results have been pretty disappointing. Even though we could achieve pretty high SVR, the management in clinical practice was a bit disappointing because of side effect management. So this study is the QPIC study, the early access French program. And basically, so the background, as I mentioned before, in the phase 3 trials with telaprevir and boceprevir, very few cirrhotic patients were included. And the SVR rates in these patients are poorly known. So the QPIC cohort, that is a compassionate use of protease inhibitor in viral C cirrhosis. This is a French multi-center observatory, so investigator-initiated study under the aegis of ANRS, the French Agency for HIV and Viral Hepatitis, in the setting of the early access program, so was in early 2011. So the observatory included 674 treatment-experienced cirrhotic patients, included in 56 sites in France. The primary objective was to determine the SVR24, and these are the interim analysis, the SVR12 in 485 patients. That has been mentioned before. Now the SVR12 is becoming the standard. So this slide summarizes the treatment regimen that was the label used for boceprevir with the lead-in phase and for telaprevir. And regarding the patient characteristics, what I already stressed, most of these patients were genotype 1, the most difficult to treat patients, majority infected with genotype 1b. And as I already stressed, most of these patients would have been excluded from the phase 3 trial. And also I want to stress that most of these patients were treatment experienced and relapser, very small number of non-responder. Going through the disease characteristics, I just want to stress that not all, but most of these patients have compensated cirrhosis. So these are the results, and you can see that SVR12 is 40% with telaprevir. Another important point, headline, is that the response to prior treatment is important with triple therapy, and the relapser achieved better SVR than the partial and the non-responder. And also, as been mentioned by Mark before, the HCV subtype is important, and genotype 1b infected patients achieve better SVR than genotype 1a. Regarding boceprevir, you can see that the SVR12 were very similar, 41%. And also, for boceprevir, the relapser achieved better SVR12 than the partial responder and the non-responder. Subtype, again, genotype 1b was better than genotype 1a. And so looking in multivariate analysis at the baseline predictor of SVR12, relapse achieved a better SVR, relapser, as I mentioned before, and genotype 1b. So this is actually the larger real-life cohort of treatment-experienced cirrhotic patients. And you can see that the SVR12 rates were pretty comparable with the result in the subgroup of patients with severe fibrosis or cirrhosis in the phase 3 trial, but lower than the other phase 3 trial which focus on relapser. And the two predictive factors, as I mentioned before, is the response to prior treatment and the HCV subtype. So this result suggests the benefit of triple combination, telaprevir and boceprevir in compensated cirrhotic patients. Now let's move on to this is another real-life study from Austria, investigator-initiated study on telaprevir and boceprevir in hepatitis C patients with advanced liver disease. And, in this study, I want to stress that 191 patients were included, but not all patients had cirrhosis, only a minority in contrast to the CUPIC observatory. And regarding adverse events, you can see that discontinuation due to severe adverse event was observed in around 20% of patients, and also severe infection in almost 10% of the population. And when you look into details, this is the Telaprevir data. Most of these patients had cirrhosis, as you can see. Similar trend was observed with Boceprevir. Most of these patients had cirrhosis. Now these are the SVR according to the fibrosis stage, and you can see that the SVR were slightly lower than the one I presented before, 27% in the F4 patients and 47 in the F3 patients. You have to take into account that it's a small number of patients, much smaller than the previous study. So to summarize and conclude, about 1/4 of patients with advanced liver disease can be cured by triple therapy. But although the frequency of severe adverse event was comparable to patients without severe fibrosis, the rate of severe infection was high, around 10%, and included 3 deaths. The predictors for septic event were low platelet counts, that are signs of portal hypertension, low serum albumin, and HVPG above 10 millimeter of mercury. So that means that in clinical practice we can treat these patients, but we have to closely monitor them because they are at risk of developing infection. Now let's move to another observational study, this time from the United States. This is still ongoing. And the aim was to evaluate the safety and efficacy of triple therapy in a broad population of patients treated in North America, including patients with cirrhosis. So this is a consortium of academic and community medical centers involved in more than 100 centers in the US. And the demographic, clinical, adverse event, and laboratory data were collected sequentially from sequential enrolled patients treated with both Boceprevir and Telaprevir. And this is the interim evaluation of available data through April 12 to 13. So just the flow charts, almost 2,000 patients were enrolled. In current analysis, there were about 1,500, of whom more than 500 had cirrhosis. And about 139 are still on treatment less than 16 weeks, still on treatment more than 16 weeks, the majority, and completed full course about 20%. Early discontinuation of all treatment was observed in around 1/4 of the patients. And this was mainly because of lack of efficacy, adverse events in these patients. So this is a busy slide summarizing the characteristic. What I want you to focus on is that, as you can see, most of these patients were infected by genotype 1A and 1B. About 40% had cirrhosis, and half of them were naive and half of them were treatment experienced. So it's a different population from the one that was included in the CUPIC study. So to summarize, you can see that adverse events were quite common, around 80%, but most adverse event, anemia was the most frequent adverse event, not only with Telaprevir, but also with Boceprevir in more than 50% of the patients. And severe adverse effects were observed in around 10% of the population. So, in this interim analysis, the safety and on-treatment efficacy of Telaprevir and Boceprevir in the real-world setting are comparable to that observed in the registration trial, but this is not the same population as the CUPIC study, as I already mentioned. And although no safety signal were observed, anemia emerged as the most relevant adverse event impacting clinical care. And patients with cirrhosis were at increased risk for severe anemia, 22% as compared to 14% in non-cirrhotic patients. And also, hepatic decompensation occurred in around 10% of patients with cirrhosis, and 2 of them, again, died from sepsis, like in the Austrian study. So the patients continue to be followed to assess SVR rates for the entire cohort. So before concluding, the good news is that in patients who fail tranquil therapy, we have rescue treatment. These are results from a phase 2 study, including 40 patients with genotype 1, most of them with genotype 1A, which is no surprise, are the one who fail, and who had non-virological response, relapse or breakthrough during prior treatment with triple therapy. And these patients were treated in 2 arms, either daclazivir plus sofosbuvir, or either the combination of daclazivir and sofosbuvir plus ribavirin. And if you look at the result, although we are missing SVR12 that will be presented during the meeting, the results are pretty impressive. Almost 100% of SVR4. I mean, we have to wait for SVR12. But the key issue is that we can rescue this patient, and this is good news for patients. So this is.
For 1 second.
Sorry.
Thank you.
So although this is a small number of patients, this is a phase 2 trial, this is a proof of concept that we have a rescue treatment in these patients that are not responding to triple therapy.